Hello and welcome. Today we're diving into a rare and devastating genetic disorder known as Sandhoff disease. Join us as we explore its causes, effects, and the ongoing efforts to understand and combat this condition. Sandhoff disease is caused by a mutation in the HexB gene. This gene provides the instructions for making a part of an enzyme called beta-hexosaminidase. We inherit 2 copies of this gene, one from each parent. For Sandhoff disease to develop, a person must inherit 2 copies of the mutated gene, meaning both parents must be carriers. If both parents are carriers, there's a 25% chance with each pregnancy that the child will inherit the disease. Parents who are carriers usually show no signs or symptoms themselves. Now, let's understand what happens in the body. Beta-hexosaminidase is crucial for breaking down fatty substances called gangliosides, specifically GM2 ganglioside. These gangliosides are constantly being created and broken down in cells, especially in nerve cells. When beta-hexosaminidase is deficient or absent due to the HexB mutation, GM2 gangliosides accumulate to toxic levels, primarily in the brain and nerve cells. This buildup disrupts the normal function of these cells, leading to progressive neurological damage and the devastating symptoms associated with Sandhoff disease. Sandhoff disease is a rare condition, affecting individuals worldwide. However, it's more prevalent in certain populations, such as the Mennonite communities of Kansas and the Romani population of Europe. Due to its genetic nature, the occurrence is linked to consanguinity, or marriage between related individuals, which increases the likelihood of inheriting 2 copies of the mutated gene. The signs and symptoms of Sandhoff disease vary depending on the form of the disease: infantile, juvenile, or adult onset. The infantile form, the most common and severe, typically presents symptoms within the first 6 months of life. These include exaggerated startle response, developmental delays, muscle weakness, vision loss, seizures, and cherry red spots in the eyes, which are a hallmark sign. Juvenile Sandhoff disease usually appears between 2 and 7 years of age, with symptoms like ataxia, speech difficulties, and gradual loss of motor skills. The adult onset form is extremely rare and presents with milder, slowly progressing neurological problems such as muscle weakness, psychiatric disorders, and impaired motor coordination. Diagnosis of Sandhoff disease involves a combination of clinical evaluation and laboratory testing. The key diagnostic test is enzyme assay, which measures the activity of beta-hexosaminidase in blood samples or cultured skin cells called fibroblasts. Significantly reduced or absent enzyme activity strongly suggests Sandhoff disease. Genetic testing can confirm the diagnosis by identifying mutations in the HexB gene. MRI scans of the brain may reveal characteristic abnormalities, reflecting the accumulation of GM2 gangliosides. While Sandhoff disease doesn't have distinct subtypes based on specific genes, it is generally classified based on the age of onset: infantile, juvenile, and adult. These classifications reflect the severity and progression of the disease. The infantile form is the most aggressive, while the juvenile and adult forms progress more slowly, with variations in the specific symptoms exhibited. Currently, there is no cure for Sandhoff disease. Treatment focuses on managing symptoms and providing supportive care to improve the quality of life for affected individuals and their families. This may include physical therapy to maintain muscle strength and mobility, occupational therapy to assist with daily activities, speech therapy to address communication difficulties, and medications to control seizures. Nutritional support may be necessary to ensure adequate nutrition and prevent aspiration. Palliative care plays a vital role in providing comfort and emotional support to both the patient and their families. Since Sandhoff disease is a genetic disorder, prevention primarily involves genetic counseling and carrier testing. Individuals with a family history of Sandhoff disease, or those belonging to populations with a higher prevalence, are encouraged to undergo carrier testing. This testing can determine if they carry a mutated HexB gene. If both parents are carriers, they can discuss their reproductive options with a genetic counselor, which may include preimplantation genetic diagnosis, CEF-PGD, or prenatal testing to determine if the fetus is affected. The prognosis for Sandhoff disease is generally poor, especially for the infantile form. Infants with the infantile form usually do not survive beyond early childhood. Individuals with the juvenile form may live into their teens or 20s, while those with the adult onset form may have a normal life expectancy, although with significant neurological impairments. Current research is focused on developing potential therapies, including gene therapy, enzyme replacement therapy, and substrate reduction therapy. These approaches aim to correct the underlying genetic defect or reduce the accumulation of GM2 gangliosides. While these therapies are still in early stages of development, they offer hope for future treatments and improved outcomes for individuals with Sandhoff disease. Thank you for joining us in learning about this complex condition.